Perfect. Welcome. Thank you guys for coming this afternoon. So these are my disclosures, although probably not relevant to this talk. So as you heard, aging is not good for your penis or your prostate. There's strong observational relationships between erectile dysfunction, ejaculatory dysfunction, and BPH. And one study showed that 35% of men between the age of 70 and 78 who have not had BPH intervention surgically already have ejaculatory dysfunction. The severity of your your severity of your LUTS also correlates with erectile dysfunction, such that 82% of men who have severe LUTS will also have concomitant erectile dysfunction. A nice study I found looking at how many men cared about ejaculation. 55% of men agree or strongly agree that ejaculation was an important part of enjoyable sexual experience, although one of the recent talks quoted an even higher rate. So I take this into consideration when you're looking at patients with larger glands who are more likely to experience some ejaculatory dysfunction. A patient who feels that this is an important part of their sexual function may have a different experience for their BPH treatment side effects than a patient who's not sexually active or who doesn't find ejaculatory function to be an important part of their sexual function. I remind residents all the time that size matters. Okay, so when you're choosing an appropriate BPH treatment, the size of the gland and the detrusor function should dictate your surgical management options for that patient. Okay, while mist is very attractive, it's not typically appropriate for glands that are larger than 80 cc's. And the AUA guidelines are very clear that the recommendation is either endoscopic enucleation or simple prostatectomy for glands that are large or very large. I would also add that that's also the appropriate choice for patients with impaired detrusor contractility or an atonic bladder. They're going to have very low success rates from mist. So let's talk about sexual dysfunction after Holep. The most robust study that was just published in March of 2024 comes from the Indiana group. At a 2.5-year time frame, they had 277 patients who had completed preoperative, SHIMS, and MSHQ questionnaires, as well as 6 weeks, 3 months, 6 months, and 12 months postoperatively. So with all of these studies, the baseline erectile dysfunction rate is quite high. In this study, it was 56%. So they found no change in IIEF from preoperative to 12 months postoperative. And if you look, their IIEFs are really quite low, 11 to 13. But they did find statistically significant declines in frequency of ejaculation, strength of ejaculation, and volume, but did not find a difference in bother, similar to other BPH studies. Another large cohort comes from a German paper with 4 centers, 235 patients looking specifically at IIEF scores. 13% of their patients reported an improvement in their erectile function. 16% reported an impairment in their erectile function, but overall 68% of them had preoperative erectile dysfunction. So when they did a little subset analysis for patients who had good erectile function and IIEF of greater than 22, they did find that there was a statistically significant decrease in their IIEF from preoperative to the 3-month and the 12-month mark. And this was the only study that I found that had that difference in their erectile function group. At 3-year follow-up, this other large cohort study from Dr. Humphreys out here in Arizona with 243 patients, again, baseline IIEF scores were very low at 13. He adjusted for the use of alpha blockers, 5-alpha reductase inhibitors, total energy used during a Holep, and found no difference as well in the group that was actually sexually active preoperatively to where they were at 3 years postoperatively. There have been some publications about some alterations in techniques of enucleation to try to spare that ejaculatory hood, with one study showing that just by sparing the ejaculatory hood by going 1 centimeter proximal to the vero and 3 centimeters lateral when making your initial incisions, they had a 60% antegrade ejaculation rate. And there's another very recent study of 450 patients who got median lobe only enucleation, and 87.5 of those patients had preserved antegrade ejaculation and a great improvement in their IPSS score. But I would also remind you that this is probably not an appropriate recommendation for a patient with impaired or atonic bladder, because I don't think you would deobstruct that patient enough with a median lobe only Holep to allow them to void spontaneously. How about sexual dysfunction after simple prostatectomy? And to be honest, the literature wasn't lovely. A lot of the cohorts were relatively small, and a lot of the cohorts also contained variable techniques in the way that the simple prostatectomy was done. One recent publication showed an antegrade ejaculation rate of 55%, and that was in a cohort of patients who had variable techniques in the way that their simple prostatectomy was done. There are some urethral sparing approaches, which show 81 to 93% are able to maintain antegrade ejaculation, but again, relatively small cohorts. Similar, again, when looking at erectile dysfunction, many study sizes were 60 and 70 patients. They didn't include all of them having pre- and post-operative IIEFs. The best study I could find was published in Endourology in 2016 and compared 236 men who either had a laparoscopic simple, a robotic simple, or an intrafascial robotic simple prostatectomy. And they had IIEF scores pre-op at 3 months, 6 months, and 12 months. They found that the patients who had the intrafascial robotic simple prostatectomy, and as my understanding, that's a bit of a wider margin, they did have a change in their IIEF scores from preoperative to 6 months, but had returned to their baseline by 12 months. And in the entire cohort, there was no overall statistically significant change from pre-op to 12 months post-op. And finally, I'll talk about prostate artery embolization. And I'll say this, I fit this in my mind into a little bit of a different category. I think about it as a minimally invasive surgical technique because I'm thinking about outcomes when I look at changes in PVRs and changes in Qmax and IPSS scores. So really the best study comes from Bruce Cava's group of 167 patients specifically looking at sexual dysfunction preoperatively and postoperatively. So they have shims at their baseline. Their scores were 18, and then they looked at 3 months, 6 months, and 12 months postoperatively. And overall, they did not find a change. They had a subgroup of 10 patients in this cohort who reported a decline in their shim by greater than 5. And so they looked specifically at why these 10 patients had it, and they couldn't find any difference in baseline comorbidities, previous BPH therapies, the technique that was used for the embolization, and importantly, the question people have, so if you remember that the vasculature of the prostatic artery is quite variable, and it can come off the pudendal or the accessory pudendal. And so there's a worry that if you are embolizing something off of the pudendal that you could contribute to erectile dysfunction, but they did not find that that was contributory in their study. Okay. Anecdotally, 4 patients also reported retrograde ejaculation, but I don't believe this study had ejaculatory dysfunction questionnaires pre- and post-operatively. Another large cohort study looking at 630 total embolization patients. 63% of those patients showed no change in their IIEF or an improvement from pre to post procedure. Of the patients that did note a reduction in their IIEF score, it was by 3.8 points, which wouldn't be considered clinically significant. I'm going to throw a little bit of shade at prostate artery embolization because this is a very big cohort, but if you look at their long-term follow-up, their only change in Qmax was 3.3 cc's per second, and their change in PVR was by less than 2 ounces at their long-term follow-up. So again, this fits more in the category of the outcomes for MIST rather than comparable to simple prostatectomy or Holep. And finally, the best article I could find about retrograde ejaculation after embolization comes from BJU, where there was a 24% reported rate of retrograde ejaculation after prostate artery embolization. It's a bit higher than I would have expected. Prostate volume decreases by about 30% when you do an embolization. You don't do anything to the ejaculatory hood. So they didn't have a great explanation for it, but that is something that they did pay attention to and note in their study. So the takeaway points that I want to give you today is Holep has a very high rate of retrograde ejaculation when done in the standard template. I counsel my patients in the office that it's going to be 100% or either going to have no volume or decreased volume. And if they have some, I consider it a victory and they think that they have some wonderful outcome that is, an enigma. But erectile function does not seem to be affected by Holep in the large portion of studies. Simple prostatectomy techniques can mitigate retrograde ejaculation, but the data on erectile dysfunction is poor in the literature. The series are small and they're mixed in their techniques. And then prostate artery embolization does not seem to affect erectile dysfunction, but reported rates of retrograde ejaculation have been variable. Thank you.